Good morning, good afternoon, and good evening to colleagues from all over the world. Welcome to Season 3, Webinar number 2 of the WSPOS Worldwide Webinars. Today, we will be exploring the challenges of managing glaucoma in anterior segment dysgenesis. It is an enormous honor for me to introduce our two special guests and discussants. Alana Grajeski is the Professor of Clinical Ophthalmology and the Director of the Samuel and Ethel Balkan International Pediatric Glaucoma Center at Bascom Palmer Eye Institute at the University of Miami in Florida, USA. We are delighted to have you as part of the team. Thank you so much. Prof. David Walton is the Clinical Professor of Ophthalmology, Massachusetts Eye and Ear Infirmary at Harvard Medical School, Boston, Massachusetts. He's also the president of the Children's Glaucoma Foundation since 1999. Prof. Walton, thank you so much for joining us today. Next, I'd like to introduce Ken, and anyone who has attended previous WSPOS webinars will know Ken well. He's the Division Chief of Pediatric Ophthalmology at UPMC at Pittsburgh, Pennsylvania, USA. He also is very involved at the UPMC Center for Rare Diseases Therapy, and this is where Ken sees rare developmental disorders, and we look forward to him sharing many of the cases that he sees. My co-moderator is the distinguished Alex Levine, who is the Chief of Pediatric Ophthalmology and Ocular Genetics at the Pflaum Eye Institute. He's also the Chief of Pediatric Genetics at Golisano Children's Hospital, University of Rochester, New York, USA. I hand over to you, Alex. Next slide, please. Alex, you're muted.
Thank you, Nicole. It's a great pleasure to be here among such an astute group of people. David Walton, in particular, who is the king and father of pediatric glaucoma, probably the most famous glaucoma person in pediatrics worldwide. And Ken, thank you very much for organizing these incredible webinars time after time. You just do a great job. I'm pleased to co-moderate this with Nicola Freeman, one of the most known people on the African continent taking care of pediatric glaucoma. She's head of the Department of Pediatric Ophthalmology at the Red Cross Children's Hospital in Cape Town, South Africa. Gorka Sesma, chairman of pediatric ophthalmology from the King Khalid Hospital in Riyadh, Saudi Arabia. Ellen Bitrian, associate professor of clinical ophthalmology from the Balkan International Pediatric Glaucoma Center in Bascom Palmer, Miami, Florida, and Gurjit Jutli from Oxford University Hospital. And I just want you to know that currently we have listening on this call people from Indonesia, Serbia, Italy, Spain, Argentina, Russia, Bosnia, Malaysia, Sweden, and it's just a fabulous outreach, and many thanks to Ken and David Granite for making that possible. Some housekeeping items. We can have the next slide. If you have questions, type them into the YouTube comments section. They're being moderated and sent to Nicola and Di, and we will bring them up where appropriate during the session. For your attendance and participant certificates, just email programs, spelled PROGRAMME, at WSPOS.org. And lastly, I am going to turn it back over to Ken for his talk, and Nicola, go ahead.
Thank you very much. I think I'm going to ask Akila to play a video because my internet connection is a little unstable. So I'm going to let Akila play that. I can't hear any audio. Can you hear audio?
No.
Okay, so I'll just talk over it. That's fine. So I think what
asking you to think what the eye needs to look like at 16 years of age when you have an infant with aniridia who has glaucoma. And really, I want to talk about goniotomy, the armored tube, and cyclodiode laser. And I don't really use trabeculectomy with trabeculotomy with mitomycin in cases of aniridia. But before we talk about the management strategies, I just want to point out that aniridia is lack of the iris, either complete or partial. The classical type is due to mutations in PAX6, but there is a whole bunch of genes that can cause a similar phenotype of the iris, but they don't cause nystagmus, they don't cause pannus, they don't cause limbal stem cell deficiency, they don't cause foveal hyperplasia, and they don't cause optic nerve hyperplasia. But all of these genes, FOXC1, PITX2, CYP1B1, TRIM44, and FOXD3, can cause a phenotype of lack of iris. And it's important to know that. Why? Because if it's PAX6 related, then the limbal stem cell status plays a role in whether you're going to use antimetabolites or not. And also in PAX6 related aniridia, there is a potential role for goniotomy in prophylaxis of glaucoma. So here on the left is a child with complete lack of iris due to a mutation, actually it's a deletion in FOXC1, and on the right, a child with a mutation, an intergenic mutation in PAX6. Prophylactic goniotomy for PAX6 related aniridia glaucoma was first described by Dave Walton, who's on this webinar as a discussant today. And what they showed was that, in a substantial number of those patients, there was no glaucoma developed, and 6 were controlled on 2 drops. The rationale is that if you look at the iris stump that remains, it sort of closes up. So if you can create a recession by doing your goniotomy, that stump doesn't close and doesn't cause this glaucoma. So if you see here, this is at the top, a child with primary congenital glaucoma. You can see that the ciliary body is not seen, and there's a concave insertion. At the bottom, this is what we call a normal infant glaucoma. And here on the right is a child with aniridia who has an angle very similar to that seen in PCG. So this is an example of a prophylactic goniotomy in aniridia. There is a little bit more iris stump than you would perhaps expect, but the angle itself looks like that you'd expect to see in primary congenital glaucoma. Now, here's the issue. It's exactly the same goniotomy that you would do for primary congenital glaucoma, but it's psychological. You don't have that iris to protect you from the lens. But once you get over that, you can see that as you cut, the iris remnant drops back, and you see that recession develop really quite nicely. So that's prophylactic goniotomy in aniridia. I do it. I now want to talk about the armored tube technique that I would use in aniridia. And the only thing I want to point out that's perhaps a little unusual is that I will use a 6-ovicral ligature suture, even though the armored tube has a valve that's supposed to stop the tube from overdraining. The reason why I do that is that children's corneas, sclera are very elastic. By the time the pressure drops, you tend to get choroidals. So it's too late. This child actually had a corneal transplant, had aniridia, and I placed the tube in the supratemporal quadrant. I do the ligature. This is a nice way of showing that I do a 25 gauge entry, and you can see how the tube is pinched nicely. And then I'm using the OCT. I can see that I've closed it properly. And that's what it looks like at the end after I've placed the irradiated cornea over the entry site. So I want to talk about, lastly, when should you think outside the box? Say, here's a child who is 5 days old, right axial length was 19.36 millimeters, left axial length 19.33 millimeters, clearly much longer than it should be. But the anterior chamber depth was only 1.9 millimeters in one eye and 2.1 in the other. This is what it looked like after we'd given a Diamox and tried to reduce the pressure. This child actually had FOXC1 mutation, and in my experience in Axenfeld-Rieger, goniotomies are not that successful. So if you look at this anterior chamber depth, that's the anterior chamber depth at the top initially. Then I did a procedure and allowed the child's anterior chamber depth to increase so that I could place a tube safely. So what I did was cycloablation. I use a high-frequency ultrasound to delineate the position of the cerebral processes, but in this particular case, you could actually see when you were delivering the energy ab externo. And this is what happens. If you get a pop, it looks like this. You really want the picture on the bottom left immediately after the laser. These pictures are taken immediately after the laser is applied. So I did that, the eye got deeper, and I was able to place a tube down here, you see in the supratemporal quadrant, and all is good. Why do I do that? So by the way, this is the optic nerves. They look recently taken, look healthy. But why do I do that? These are cases referred to me, both actually with Axenfeld-Rieger, who both had tubes in the first 3 months of life. And you can see that this one has, glaucoma, loss of zonules here. And this child actually, the tube rubbed against the cornea and he got a corneal melt. And this is me putting a Goodison flap on to try and save the eye. So I'd like to think what the eye needs to look like at 16 years of age, and therefore I will use goniotomy in cases of aniridia, either when there is no glaucoma or when the glaucoma has just started. I will use the Ahmed tube, but I will use cyclodiode laser to buy time. Thank you.
Nicole, you're muted.
Me? There we go. Thank you. Ken, thank you very, very much. You'll be interested to know that there's already been a question about your one case of the one case, and you've actually answered that. So thank you very much. Are there any questions for Ken from the panel before we go on to Gorka's talk? Does anyone have any comments? Prof. Walton, do you have?
I have a question for you. Yes. Ken, did you consider doing ab external 360 trabeculotomy as opposed to going straight to an Ahmed shunt? I mean, you could have done that without deepening the chamber. Just curious if you've considered that, because we have used that with some success.
Yeah, no, and I think Alana, there are people who have described good results with the technique that you're describing. So one of my problems is that being a pediatric cornea specialist and dealing with the anterior segment, I tend to see the cases that have gone wrong. So I saw a child who was referred to me where that procedure was done with a 360 suture, Proline. And but about 50% of Decimase was stripped off at the same time in an infant. I'm not talking about older children. And basically, it was almost impossible to try and save that cornea. I tried to do a DSEC. So the answer to your question is that I have not done that, but I know people who have. I think also the issue for me is I haven't probably done enough to feel confident to do them in the really difficult cases. And I think that that's really what it comes down to. You know, you have to feel confident that in the difficult cases that your muscle memory and your surgical expertise is safe.
Yeah.
And
there's also the concern that in PAX6 mutations, you may not have a viable Schlemm's canal for 360 degrees. And then you get into trouble. You get part way, you got to cut down, part way, where you can't. So I would.
Well, you resort to a trabectome at that point,
Yeah.
You can't go around.
Okay. I mean, I would be interested. Yeah. Go ahead, Dave.
Can I like to make a few comments about your presentation, which was excellent, and you're one of the few ophthalmologists who's really adopted the prophylactic procedure, and I'd like to make just a few comments about that. The prophylactic procedure is something that should be considered in the first 2 to 3 years of life, if not the first year, and doing it really depends on observing progressive changes in the angles. So gonioscopy during the first year of life is really important to see whether or not those progressive closure changes are occurring during the first year. A child is really not a candidate for it during the first year of life because the anterior chamber is so shallow, but it affords the opportunity to see whether the changes are occurring. Gonia surgery, by and large, does not work well in aniridia. There are a few exceptions where it has worked well, and gonioscopy has suggested that it might, because on gonioscopy, when I've had it successful, and just a very few instances, is when the trabecular meshwork was unobstructed and looked really normal. I would just like to comment on the pathology of aniridia, that it's not an angle closure glaucoma. In other words, it's not a phenomena where the stump of the iris rotates up and covers the meshwork, but it's rather a crawling forward of the iris tissue itself over the deep trabecular meshwork. And one sees that on gonioscopy. When you look at where the iris is inserted, you'll see a fibrovascular membrane extending from the iris insertion up over the trabecular meshwork. So when one does or use the goniotomy knife to do the prophylactic surgery, you do just exactly as you showed beautifully. You engage the tip of the knife in the iris and pull a little bit posteriorly, and it comes off the meshwork. In fact, when I do it, I try to avoid cutting anything except just the initial engagement of the iris. And so what you're really doing is disengaging this peripheral iris, which is crawling up onto the trabecular meshwork. Why it doesn't reoccur is really puzzling to me. But in fact, when you pull the iris off, the trabecular meshwork remains clean after that surgery. Your presentation was so good and touched so many bases. You did suggest that trabeculectomy might not be a good procedure for aniridia. I would take exception to that. I think it's a very good procedure for aniridia, and it's really my go-to kind of procedure when I have a child with aniridia and glaucoma. With that said, it's best done after 3 years of age. I'll just add one additional comment in regard to all these issues. A child who's cared for surgically with aniridia cannot be allowed to have a flat anterior chamber. And of course, we see that after any kind of surgery, not angle surgery so much, but with trabeculectomy or tube surgery, these patients have to be followed daily to absolutely be sure that an anterior chamber flatness does not occur. If the anterior chamber is allowed to go flat, the lens will come into the back of the cornea and the cornea will be destroyed. And so it's essential. And if one can't do that, then you have to find some way to do it if, in fact, you're going to do anterior chamber surgery on these patients. Congratulations, your presentation was really excellent.
Thank you. Can I ask you, may I ask, Nicola, can I ask a question of David and the rest of the panel? What are your tricks? Because when you do a trabeculectomy in a child with aniridia with, major absence of the iris, what are your tricks so that it doesn't go flat? Do you use viscoelastic at the end to form the anterior chamber? How many sutures do you put in the flat? What are your tricks to stop that flattening?
I wish there was a secret to keeping the anterior chamber from going flat. I do add Helan at the end, and that's the most judgmental part of the procedure when you have manufactured the flap And I do put vicryl sutures in the flap rather than nylon, but that judgment of flow under the flap at the very end of the procedure, when you sort of feel like possibly you're done the procedure, but in fact, you really have the opportunity then to look at the flap really carefully to be sure there's a little flow when you tickle under the flap. But you can add a suture. If adding a suture to slow flow, I would use a tenovicryl. But I think the important thing is to know that there is no secret to guarantee that the anterior chamber is not going to go flat. And I've just seen a number of eyes with destroyed corneas when excellent surgery has been done, but the follow-up has not been what I suggested with really daily. If in fact the anterior chamber is shallowing and threatening to go flat, that child must be returned to the operating room and the anterior chamber deepened. And indeed, it might have to be done even more than once. But I would like to leave that point more than anything else. You cannot allow the anterior chamber of a patient with aniridia to go flat.
Dr. Walton, do you do fornix or limbal base? And are you worried about the effects of mitomycin on these patients?
I think about it, but I'm concerned more about the glaucoma. And I really find the trabeculectomy to be an excellent procedure for the condition.
And do you choose limbal or fornix?
I didn't understand that question.
Oh, do you do limbal? Your technique is limbal or fornix based?
It's fornix based. Fornix based. An interesting question in regard to that procedure, trabeculectomy for aniridia, is whether or not you have to do an iridectomy, and actually you frequently do. The little iris will come up towards the flap, and you have to do an iridectomy. You would think that would not be necessary, but it seems to be necessary to do that when the iris presents in the sclerotomy, but it's a good procedure for that. No anterior chamber flatness.
You know, Elena, your point is, I was going to say, Elena, your point is well taken, though, that a limbus-based approach would leave the limbus and spare the limbal stem cells.
Same as we do with tube shunts.
Yes, we do that.
You really bring up such a good point in regard to aniridia and the corneal and corneal keratopathy. It's a matter of discussion. What really causes the keratopathy and aniridia? And I doubt whether 1 hour of circumferential lessening of stem cells makes any difference whatsoever. And frankly, I've never seen that localized area of worsening of the iris. What makes the iris have a progressive opacification throughout the first 20 years of life, and it's very variable with different genetic defects, but it's clearly not just a absence or decreased performance of stem cells. That's a whole later matter of discussion, perhaps not appropriate for this presentation, but it's a very interesting question, and it's not simply a deficiency of stem cells per se.
David, I'm sorry to interrupt. We've got 2 minutes left. Ken, you wanted to comment on vicryl versus nylon?
Yeah, no, I was interested. You know, I wonder how many of the panelists use tenovicryl instead of tenonylon. I've never used tenovicryl for the flap because I've been worried about aggressive healing, and I think the vicryl encourages that. But Dave, you know, you're using tenovicryl, so I'm interested. Who else uses tenonylon or tenovicryl? I use tenonylon.
I use nylon.
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 Nylon too.
That's really interesting. I recommend that you use the vicryl. It works so well, and it doesn't dissolve quickly, and you don't have the foreign body in there later on, and so forth. It works very, 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 very well. And I'm a little bit inconsistent about the corner sutures. Sometimes I'll use 9-0 vicryl, but with that regard, whether it's 9-0 or 10-0, it's very important to use a needle that has a tapered needle, not a cutting needle, because you don't want to put a cutting needle through the flap because you'll see leakage around the defects where the needle has gone through the flap. So yeah, at least you should know, at least from one person's experience, that Vicryl works very well. And I don't know how many trabeculectomies exactly I've done this time in children, but it's clearly over 100.
So we're going to need to move on to our next speaker. I just want you to know that we now have people listening in from Poland, Israel, Taiwan, Brazil, Spain, Hong Kong, and Saudi Arabia. And since Saudi Arabia came up, let's have Dr. Gorka Sesma present. And I'm very impressed that he has the only hospital with a swimming pool for the staff in the front yard there. That's very nice. So Gorka, go right ahead.
Thank you, Dr. Levine, for inviting to this important forum. Let me hold on for a second and try to run there. There you go. Thank you for inviting me to this challenging topic. Talking about anterior segment dysgenesis is challenging for all of us. And this is our reality in Saudi Arabia. Childhood glaucoma in our country, we occupy the second place in the world. And when we compare the prevalence of this country with the world, we have a lot of patients and we deal with this. In an average, we see 2 new patients per week. This is our reality. So when you see this study from India, our statistics are similar. 50% is primary congenital glaucoma and 3 to 5% is anterior segment dysgenesis, secondary glaucoma associated. That's an important question to answer. PAX6, FOXC1, PIK-X2, gene mutations are associated with anterior segment dysgenesis. But here in Saudi Arabia, we have the CYP1B1 as present in this pathology. So we need to consider this CYP1B1 in anterior segment dysgenesis, specifically in their country. We'd like to thank Dr. Amanibaki for facilitating me this nice information. She's in charge of this situation, and we need to keep it, never forget the possibility of CYP1B1 as a possible cause of congenital glaucoma or anterior segment dysgenesis. Generalizing is difficult. This is one of our situations, complex patients with difficult situations, and we need to evaluate all these things. So the treatment, in my opinion, should be tailored. This is a typical patient that we have in KKESH. Young patient with anterior segment dysgenesis. Look at the amount of surgeries. We need to think about the life expectancy. We are not including the cornea and cataract surgery. So at the end, we get married with these families. Be optimistic or pessimistic. This is the rules that we follow in KKESH. We use goniotomy when we can, trabeculectomy, trabeculotomy, combinations. We see that we have good results with trabeculectomy. But as you see in the previous slide, you knew and you saw how number of surgeries are going to be present. The UVM is a valuable tool to help us in the diagnosis and the management of these pathologies. And what about if we find the Schlemm canal, as you can see here in these studies? If we see the absence or presence of the Schlemm canal and we have an open angle, we could try deep sclerectomy as an option. I'm not saying that this is the option, but surprisingly, in these cases, you could find aqueous percolation more frequent than you can see. So this is a deep sclerectomy. The idea to do this, you can do rhomboid, triangle, squares, depending on the preference of the surgeon. It's important to see that the Schlemm canal in children is located more posterior. And when you see here, you need to go deep. Deep means deep. That's why the name of the sclerectomy. Just suprachoroidal with few fibers of sclera. When you reach the place, you need to see spontaneous percolation. Okay, if you see percolation, you keep going a little bit. And the trick here is don't peel the second flap. We close, and we usually close it loose. And basically, this is a trick to avoid perforations when you are performing the deep sclerectomy. This is good. And what about if we have a patient with reoperation? I mean, this is a patient with a previous deep sclerectomy that failed. And in this case, Dr. Sharhel decided to enter in the same place. You see, he just found the sutures. The rest of the flap, the sclera flap, was sealed. No way to find where was the previous flap. He tried, and you're gonna see when we saw the second flap, you see in the residual part of the sclera, you see how was the previous deep sclerectomy performed in this case. So he entered again. Why enter in the same place? Because it's the life expectancy. This patient probably is going to need more surgeries in the future. So we need to preserve the space and try to see if we can do something for these specific patients. So you see how spontaneous percolation of aqueous, and again, keeping the flap loose, the second flap loose. We usually, in these cases, we use mitomycin. And the closing, the first case you see for limbal, and this is fornix incision. What about if the patient has 7 months or less after the DS and the DS? So in Kekesh, we work as a team, glaucoma, anterior segment division, and pediatric ophthalmology. So in these cases, a glaucoma team decide to do needling. I know that it's controversial because when we enter, we say, well, this is not perforating, so now you're perforating. This is a nice discussion that we could have it, but this is an option, and we have patients under this situation that worked. What is the advantage? Well, you are entering, but you are not opening the eye like doing a new trabeculectomy or a new DS or other surgical procedure. So you see here a case of Dr. Rizwan Malik presented. This is a patient with a DS after multiple surgeries, and you can see in the UVM how's the scleral lake. So it's an option, no? 6 months later, and now the patient was followed a year later, and it still is, we saw them recently, and the patient still has, the DS is working. So you can, the QR code, you can scan it, like grab it. This is a study, very interesting study for Dr. Alveidan. He studied 120 patients prospective, studying the efficacy of the deep sclerectomy, and the results were around 80% of success without medication. And in the right is a running study we are doing now, comparing the DS perforating versus not perforating, and we see 70% of success. Some tips, these ones. You can convert any time if you are doing a deep sclerectomy. Some tricks is have a good window, reaching the cornea. When you're reaching the cornea, release the traction sutures, use a wet sponge, change direction, go slow, touch, dry, and watch. Touch, dry, and watch. Show it, it's as I say in Arabic, the people. So you start to see aqueous, okay, this is not the end. Keep going, change the direction, go slow, until you see spontaneous percolation without touching. Working the nasal side, because the future, probably the patient is going to need more surgeries, and reasons to failure of the DS are related with the small window or the closing of the flap. Few words regarding photocoagulation. Keep it as a let's play card. We keep it in patients with poor visual outcome or patients with a refractory to treatment on any other treatments in glaucoma. This is a study that we're running in Kekesh. And also we have this blessing clinic that is US. I know that in other countries you can have it, but here, thanks to this, we can have a correct follow-up of the patients. Also, the hospital evaluates us as a quality and management process with KPIs regarding the targeted AOP. Final is a problem, a real problem, the glaucoma. Look at the cost that can be the cost of any patient. So we have in the future two ways. One, establish a genetic panel test to the patients in risk, and you can see the right graph, how after establishing a screening program of premarital screening program, the number of cancellations of marriage due to the risk increase. Thank you very much.
Thank you. Thank you very much. We're going to hold on questions and go straight on to the next speaker. And we'd like Eleanor to give us her talk on angle surgery and anterior segment dysgenesis. Thank you. So Eleanor, you're still muted.
All right, yes.
Thank you.
Very good. All right. So here's my screen. So thank you so much for making me part of this webinar today. I'm going to talk about angle surgery, anterior segment dysgenesis. I'm an associate professor at Bascom Palmer, and we had some cases that we would like to share with you. So for pediatric glaucoma surgery, we usually think of angle surgery first. And if possible, we like to treat the 360 degrees of the angle before proceeding with filtering surgery or cyclodestructive procedures. We know that angle surgery, whether it's ab interno or ab externo, has better prognosis on primary congenital glaucoma and some a little limited prognosis in other types of glaucoma, such as anterior segment dysgenesis. Some surgeons don't consider angle surgery when they have certain cases of anterior segment dysgenesis. Anterior segment dysgenesis is an anomaly in the cornea, the iris, or the lens, and those are associated with a risk, a 50% risk of glaucoma in general. And we have different entities and some syndromes, like we know, Axenfeld-Rieger, Peters syndrome, aniridia, or oculodental digital dysplasia, among others. We know for all pediatric glaucoma, we do need to plan our strategy. We have to gather information in clinic. We have to do a very useful EUA, exam under anesthesia. But for children with anterior segment dysgenesis, that's even more important. As Dr. Sasma said, the use of UVM is crucial to plan these procedures. We can choose there's a role for both ab interno and ab externo procedures. We know that ab interno they are quicker procedures, will spare the conjunctiva, but we need clear corneas, and we don't have that in all our kids with anterior segment dysgenesis. So in cases of opaque corneas, we do proceed with ab externo procedures, and and ab externo are very useful when there's shallow chambers. There's many things we could do for ab interno procedures. We can use a needle goniotomy, like we described with Dr. Nichel described with the aniridia patients, or we can use other devices that allow for more extensive treatment of the angle, like the Omni from Sciences, or we could do also like GAT procedures. For ab externo, it's very useful, the eye tract catheter. Probably prefer rather than a Prolene suture, since those patients have anomalies in the anatomy. We want to see at all times where we are. But also we need to keep in hand the harms trabeculotomes. Sometimes those schlems are not continuous, and we do need to do a more limited trabeculotomy. So we know for a trabeculotomy, it's crucial to have a deep scleral flap, identify that Schlem's canal doing a cut down, seeing the egress of aqueous that tells us we are in the right spot. It's nice to probe with a Harms trabeculotome. We can treat completely with a trabeculotome or just do the probing before we introduce and thread with either a suture or an eye tract catheter. It's important to remind also that in those children, we need to close our cut down very well so we avoid blebs, and we need to close the scleral flap tight as well. It's nice to, I do close the conjunctiva with 10 bicrural sutures and try to bury them to minimize the discomfort for these patients. These trabeculotomies, we often do them temporally to spare the superior conjunctiva in case they need future procedures. For different types of dysgenesis, it's important to consider angle surgery. It's not for everyone, but if there are Axenfeld-Rieger, they benefit occasionally from angle surgery. And also, if they do have adhesions in from the iris, it's nice to cut them. Sometimes we can cut them with a trabectome. Aniridia has been mentioned extensively, and there is a role for angle surgery in some of the patients. In Peters anomaly, it's one of those cases that the examination is very important. As you can see here, we can see the strands that from the iris to the cornea, and these kids benefit from cutting those strands. This is a nice paper from Dr. Grajewski from a couple of years ago that shows a case. We see the two superior photos. This child has bilateral Peters with significant corneal clouding. She did a triple procedure on one, which is an ab externo trabeculotomy, cutting the adhesions and doing, as you see here, optical sector iridectomies. It's more than 3 years later, this child has pretty good vision and pressures are controlled. And you can see in this video how she's piercing and breaking the adhesions and then performing the sector iridectomy. There are other cases that are hard for us to know what is which without genetic testing. And this is a child we just had at Bascom Palmer 4 weeks ago. We took for surgery. He's a 2-month-old, and we can see there's a unilateral abnormality with high pressures and ophthalmos on the right eye. This eye has a completely flat chamber and a very small correctopic pupil supernasally. And there's a membrane, vascularized membrane on this area. Pressures were very high, and this has happened, the growth of the eye in the last 3 weeks. So we did a UVM, and that's another example where planning is crucial for these children. We see the iris is here on this red line. This is the lens, and there's a thick membrane, vascular membrane, pulling towards the cornea. On this child, that's an example where we did angle surgery, like a localized external trabeculotomy. Notice how we pierce with a trabeculotomy into the anterior chamber, and we don't put the whole harms inside of the eye. We just keep it just enough to open the drainage. Also notice there's a more abundant amount of blood coming out of our sclerostomy. This is a special case. We're doing this to control pressure instead of doing a cyclodestructive procedure. This eye has low prognosis, but we need to lower the pressure to avoid further growth of the eye. Special situations, coloboma and glaucoma, we can see defects on the iris that sometimes correlates with defects on the Schlemm's canal. In those cases, I like to still try to see how far we can do and explore the Schlemm's. So we use an eye tract catheter because we can see that we are in the right spot, but then we thread a little bit more, and despite not finding resistance, we can see how the light has gone far too posterior into a collector channel. We can try the other way, but here we notice there's a hard stop. There's no way to go past this entrance. And this is one of the cases that Harn's trabeculotomy comes so handy and allows to perform a 4-hour treatment of the angle for this patient. So in conclusions, angle surgery is safe for pediatric patients with glaucoma anterior segment dysgenesis. It's nice to attempt to treat the angular 360 when possible. There's modifications that will be necessary for the surgical technique, and tailoring the procedure to these patients is very important. Thank you.
That's great. Thank you very much. So there are 2 great talks, and we're right on time. I'd like to open up for discussion by just making one comment and ask one question. I hope the audience is getting a feel for the importance of phenotyping and genotyping in these patients. You know, not all aniridia is the same. Some is PAX6 aniridia, some is, as you heard, FOXY1, but that is a different phenotype, both prognostically and surgically. So when you can get a genetic testing, that is helpful. And careful phenotyping using ultrasound biomicroscopy is also very helpful as well. One question I wanted to bring up to start the discussion going is, I'm very concerned when a patient has Axenfeld-Rieger, for example, or very shallow anterior chambers you just showed, about using ab externo techniques. I think that the rate of getting a Decimase strip is higher, the rate of getting cyclodialysis is higher. Perhaps you could comment on those considerations. Elena, why don't you take that?
Sorry, because I had, excuse me, sorry, because I had some things on with my screen sharing. So could you repeat the question, please?
I was asking about the concern about getting, using ab externo procedures in patients with Axenfeld-Rieger or shallow chambers, increasing the risk of cyclodialysis or Decimase strip.
Yes. So when we go, that's a great question. So sometimes we can cannulate, and I had patients that I've been able, that it's challenging. I've been able to go 360, and I'm concerned about the shallowing because the iris, you cannot flatten it down. And in those cases, sometimes what I've done is like just retract my eye tract catheter and viscodilate, and then just do go with my Harn's trabeculotomy and treat just a partial treatment, like you saw on this video that I show with a the last child. So I just do a localized, and I don't dare. In some cases, it is true, depends. That's what we say about tailoring and individualizing. Sometimes that you can go 360 doesn't mean you can go and treat the whole area. You can sometimes viscodilate and treat the angle for just 5 clock hours.
Go ahead, Gorka.
I have a question, Elena. How often, when you are using the eye track, you find that you are moving the eye track and you find no more road in the process of the how often? Is often for you to find this?
So depends on the case. On PCGs, way less often. We also have done, and we just wrote a work on repeated angle surgery. So on those repeated angle surgery on PCGs, a little more often. On anterior segment dysgenesis, that's way more often. I had a child that I didn't include because time is limited, that I always try and go to look for a Schlemm's canal. I think I owe that to the child instead of going to a cyclodestructive right away. In some cases, the Schlemm is not even able to find. We were not able to find it. Other cases is like this coloboma that there was no point that I did. It was such a small area that you just treat with Harm's trabeculotomy. I think the more disorganized the eye, the more likely it is that happens. Yes.
I'll throw out an idea for comment. Like Ken, I rarely use 360. I find I can take a needle much cheaper, much quicker. I don't need to cut any conjunctiva, do a goniotomy for 120, 180 degrees. And I'm not sure we know that 360 has that much of an increased benefit in terms of outcome to justify cutting conjunctiva, taking the more time and the more expense over a single needle procedure. So I'm just going to throw that out as a controversy for discussion. Maybe David and Ken, would you like to comment on that?
So, and how about when your cornea is cloudy? You do just 180 with a Harm's trabeculotomy?
I do it endoscopically. Endoscopic goniotomy. Ken, what are your thoughts?
So I have to declare a conflict here because, as you know, Alex, and maybe some people don't, you trained me 24 years ago. So I, a lot of what my glaucoma techniques are, although they change with time, they're based on what you taught me. So I would say that I did attempt to do the Prolene. I've never used the eye track, but I've used the Prolene, and I found that I had some successes, but my reliable successes were with a goniotomy. Now, I do not do endoscopic goniotomy. If it's cloudy, then I do a combined procedure, trabeculotomy. Now, if it's aniridia, I don't tend to do trabeculectomy. I do cyclodiode laser, but I do guided cyclodiode laser ab externo using high frequency ultrasound. And we've published about this. And you can pick off ciliary processes as you do that. And the one thing I do want to say is that doing cyclodiode laser in an infant or in a toddler is not the same as doing one in a 20-year-old or a 30-year-old. I have never seen a child have an eye go hypotenuse because they had 3 cyclodiode lasers in the first 2 years of life. I've never seen it. I don't know if anybody else has.
But Ken, what you do wind up with, though, is an eye that's been treated with cyclodestruction. And then if you need to do something else, like, for example, let's say a glaucoma drainage device afterwards, those eyes can wind up getting too low because you've knocked off some of the ciliary body. And I highly recommend, before you abandon, as great of a surgeon as you are, before you abandon 360 because you've tried with a Prolene, try it with the eye track. Alex's point is well taken on cost, but that requires a clear cornea, Alex. So, and when I'm in there doing a goniotomy, you're right, you can treat 180, but you could just do a GAT just as easily, or with an Omni device, you can do a 360 viscocanalostomy and maybe, and then do a trabeculotomy as well.
But Ilana,
I just want to clarify one of my comments, and that is that I would not use the endoscopic goniotomy in a patient with aniridia. And I would not use endoscopic goniotomy in a patient where the cornea is so cloudy that you can't see your instruments inside the eye. Those are 2 contraindications to endoscopic goniotomy.
So Alana, one of the things I want to make clear is these webinars are being listened to by people in parts of the world where to use an eye track would be 1 year's worth of wages for patients. So we have, you know, when we discuss these techniques, I'm trying to discuss techniques that are applicable in most parts of the world. And here's the other thing.
We start with a proline, Ken. We start with a proline, you know, and we try to use that first.
Yeah, no, but I just want to, I'm not going to labor the point, but this issue, and I'll go back to what I said. I have never seen, I had to go up to a maximum of 3 cyclodiode lasers, inferior 180 degrees, before I stop and say, okay, I'm going to have to do something else. But in terms
just
of
Kate, just to make sure that everyone understands, you do 3 cyclodiodes only in the inferior 100.
Yeah,
and 80
only
degrees.
In inferior. And
because you don't want to scar the conjunctiva in the superior 180 for future
and
for filtration procedures. I just want to make that clear that everyone understands that.
Yeah. And I think the other thing also is, and maybe I should publish this, every time I go back, and I'm talking about infants and toddlers, the places that I have actually lasered, and I've got proof that they were lasered because you can see it immediately afterwards, those ciliary processes are back to where they were.
They grow back. Yes.
The infant toddler eye does not behave like an adult eye. And I think I need to publish this because when I showed it to my fellows and I said, look, you go ahead.
I've gone back endoscopically.
So Ken, you have very poor success.
Exactly the same.
You know, but if you allow me, I would, because we have general ophthalmologists attending today the audience, no, and I would like we clarify that, you know, cyclophotocoagulation should be reserved for no as a second, or no, like, in my opinion, should be as a let's play card. You know, we have differences. For example, in the cases that we face here in Saudi Arabia, we see hypotonus, we see choroidal attachment, we see phthisis, we see complications related to the CPC. So that's why we use it, but we use it as a when the visual prognosis is reserved, and when the patient is refractory to other treatments. No?
But Gorka, again, you are doing CPC. Generally, most people do CPC by using transillumination. I'm doing CPC by using high-frequency ultrasound, actually marking out where the ciliary process and the ciliary body is, and delivering it without a pop. So, and this is published. And I don't understand why people don't use that technique. I mean, it's such an easy technique. You don't have to enter the eye, and you can pick off ciliary processes by using high-frequency ultrasound. Most people have it.
Ken, would you like to clarify what you mean by high-frequency ultrasound?
And Ken, while you're doing that, we have a question from the audience, and just to change the topic a little bit. And you're on a high-frequency ultrasound. How do you identify Schlemm's canal in a grossly ophthalmic eye? And perhaps you could answer that, and also Elena and Alana. That's a little bit of a tongue twister. Can also say how they do that as well. Some of these eyes with Dysgenesis is tough.
So I have not. Yeah, go ahead, Elena. You go ahead first.
I think that's basically an art. It's just doing a flap that is deep enough on the setting and starting posterior enough, and just trying to see where the scleral fibers transition, and just being cautious, like just doing a little cut down, spread the fiber side and side, not being too aggressive and cutting down and then having losing anterior chamber. But it is challenging to everyone, even when there's like a lot of experience. Every eye is a little bit different. So yes, it's humbling, this finding the Schlemms.
So my trick, Elena, again published, is I asked the anesthesiologist to compress the jugular on the side that I'm operating on. And when you do that, you get backflow of blood, and it goes into the episclera and into Schlemms. So when I'm doing my cut down, blood comes out, not fluid. And where the blood is coming out, I know that's Schlemms. So you get the anesthesiologist to compress the jugular on the side that you're operating on.
David, I think you had a comment. Did you put your hand up, David, for a comment?
It's been such an excellent presentation. I'd like just to comment that it really is important to, and this is just a step back from what we're talking about relative to the angle procedure, but it's really important to try to understand the diagnosis of these patients. And we really should, when you have a patient with corneal opacification and possibly glaucoma, it really is worthwhile to review the causes of glaucoma in children, and when the cornea is really opacified, to marry that with a review of the causes of congenital corneal opacity in the newborn. And it's really a very extensive group of primary things. And if one is consider seeing or for the first time a child with a newborn or a young child with corneal opacity, and you're not sure about where to get information, what I would suggest is that you review Ken Nishal's papers over the last 20 years. He has studied this category of patients extensively, and his contributions to this whole area of consideration, making an appropriate diagnosis, is really important. And in the realm of the important things, which are the most common, to consider the eye changes with newborn glaucoma, or Ken has called it CYP1 cytopathy, is really important. And because those patients, as seen frequently in Saudi Arabia, really have a different indication. And I would just finish by saying gonioscopy is really important. And we report that the results of these various procedures with very little description of what the angles look like. And for example, when gonioscopy is done with newborn primary congenital glaucoma, the kind that you do see in Saudi Arabia, it becomes perfectly clear that any of these angle procedures are not indicated. And because with newborn glaucoma associated, particularly with the CYP1 cytopathy, as Ken has coined it, there's just very little angle there. So I would just emphasize that to try to understand what your patient has in terms of diagnosis relative to corneal opacification and glaucoma is really essential. And then gonioscopy, to really study the angle and to be able to report your results relative to what the angle anomaly is really important. It's really unfortunate to see a child who's failed angle procedures for 2 or 3 times and on gonioscopy, in fact, has very little trabecular meshwork there. So I would really emphasize that point.
David, you normally can't see it anyways because it's opaque cornea to do the gonioscopy. You know, I mean, seriously. And I think that if you can get around 360 with a proline or something, there's enough of an angle there that you should at least give the kid a try with something that is not that, you know, it's not as if you're doing something harmful.
The signs of newborn glaucoma, or so-called CYP1 cytopathy, are so conspicuous beyond the glaucoma and beyond the corneal opacification that they have characteristic iris changes as well. If you make the diagnosis of that category of corneal opacification in children, and it is often associated with a CYP1 defect, the probable success of any kind of angle procedure is minimal, and in that regard, have you ever had a successful case of angle surgery with newborn glaucoma associated with those signs of newborn glaucoma, including the iris changes, which I won't go into that, but you're familiar with them? I'd like to see that report or learn about that patient where an angle procedure has been successful in that category of congenital corneal opacification or glaucoma with or without.
I'm going to step in just here. So we're running into the next talk. So we'll let Nicola sign off. There are some questions to the YouTube channel. I know Ken has answered some already in the YouTube channel. But we can get to them a little bit later. So Nicola, if you want to introduce our next speaker, I think we're good to go and on time. Thank you.
So,
Nicola,
Nicola, yes. Can I just say very briefly, I just wanted to say for the whole audience, cyclodiode laser, I'm just asking people to think outside the box and use it to temporize. So I'm sure we'll discuss that further. Okay, thank you.
I was wanting to ask that, but we need to move on and then we'll have a long discussion afterwards. Thanks, Ken. Our next speaker is Gurjeet, and he'll be telling us about tubes in anterior segment dysgenesis. Gurjeet, thank you.
Thanks, Nicola, and thank you, everyone. Really a lovely talk, and thinking outside the box is the nature of my talk as well, so it's a great link there. Just a little bit about me. I work in Oxford. I love food, love sports, love music, and love spending time with my wonderful wife. I love Star Wars. Do or do not, there is no try. That's going to be a quote we'll come back to. We've seen some wonderful classifications, looked at surgical options. What happens, I know we've discussed and debated a lot about if they don't work. So I'm going to talk a little bit about, let's imagine they haven't, and different tube techniques. We've heard vicral ties for the armored tube. So I'm going to be thinking about different types of tubes. Pitfalls and complications are an important topic. The literature is out there, we can read it, but important to look at our own experiences and learn from each other. Then we'll wrap up. This is a great book, great classification. So in childhood glaucoma, I'm going to be concentrating that which is in red, which is essentially post-lens surgery and associated with non-acquired ocular abnormalities, the Anterior dysgenesis syndromes and corneal opacities. So we've seen and discussed different surgical options. Let's imagine they haven't worked, all of these DS, CPC, etc. What about trabeculectomy? And I know David's spoken about this, but it's a good option. However, bear in mind, there's inherent tendency to scar in children, higher risks of infections, and difficulty in manipulating the surgery post-operatively with recurrent GAs possible and required. How about an anterior segment tube? Difficulty is the anatomy in these ANSEG patients. There will be PAS, difficult anatomy, and the view may be obscured, particularly in the periphery. So to go back to the quote of Yoda, there is no try. If you think something's going to fail, why not consider a primary pars plana tube, which was first described in 91. First question is about how equivocal it is with anterior segment tubes. There was a meta-analysis by Wang et al. In 2018, which showed equal pressure reduction in both groups. How about safety? Well, you can conceptualize if the tube is away from the cornea, there's less likely to be endothelial cell loss. And actually, Seo et al. Showed that the density was far more well preserved after 18 months in their paper. We've discussed indications being and seg dysgenesis. What about NVG? Can be seen in kids with Coats disease. This is an adult patient that I did endolaser at the same time, which is essentially switching off the tap for further stimulus for NVG. So that could be an indication, particularly in adults. Of course, anything we do in life, heed caution. These ophthalmic, long eyes with thin sclera. Be careful with the pass that you make. Bear in mind also the size of the plate. If we're going to put it in the superior nasal quadrant, for example, there's a potential for inducing an iatrogenic browns. Anything in life, as we discussed, there are risks. How about, and we're going to the back of the eye, there's a potential of RD. If you look at the population, if you look at the literature, they quote between 0 and 20% risk of RD. And we'll look at ways to minimize that risk a bit later in the talk. Most glaucoma surgeons have definitely seen hypotony in their practice. And in my pars plana tube series, I've seen 2 patients that have been settled medically. So if we start thinking about the etiology of hypotony, let's say in the anterior segment tubes, you could have existing trab with some flow, ciliary body shutdown, and some flow around the tube, which we can try to minimize at the time of surgery with a Tenon's plug or suturing around the wound. In the pars plana tube, it's a more tight and snug fit. So flow around the tube is less likely. Furthermore, you're actually going to suture the sclerostomy sites, meaning that it's a really closed system. Hence, the likelihood, and like Ken, I would do a 6-0 vicral tie and make sure it's tight, almost sort of embedding it within the tube. If it's a closed system, you're less likely to have to open it up and see with exploration, atropine and reducing steroids is suffice. Imagine a situation where a pars plana tube is in situ and the pressure has been controlled, and you find it's gone up months or years down the line. A differential would be to use the B scan first to see if there's flow. If there's no flow, there's probably a blockage. Where that blockage is going to be is vitreous wick, and we'll talk about how to avoid and manage that later on. Just a word of caution, this patient was listed as being previously vitrectomized. I put some ports in and you can see some peripheral gel, which I took out. The importance of mentioning that is when we're doing this kind of procedure, the vitreous base needs to be removed. Otherwise, it will block the tube and you will have a failure. Occasionally, that needs to be indented vitrectomy, which is not something that I'm doing here. I find erosion exquisitely difficult to manage. I've had 2 patients that have had recurrent erosion despite revisions with AMG, autologous grafts, tutoplast, and in both cases I had to remove and explant the tubes, and they were failures. This is a picture of mine when I was a fellow with the courtesy of Professor Bloom, who was my mentor at the time. It prompted us to do a literature search, and we found that the younger age and those with pre-existing inflammation were higher risk factors. This picture is post one of those failures, and you can see the conjugates closed nicely here, and we didn't realize that it would keep eroding through. One of the case series we found by Bayer et al. Agreed with our findings, where they looked at all of their exposure groups and found that 45% of those patients had NVG, just something worth bearing in mind if listing these patients. Regarding case series in the literature regarding pars plana tubes in children, the first one is Varma et al., which looked at 13 patients, 2 of whom were children, and they noted that the RD rate at 1 year was 0. 2 specific pars plana tubes in children groups, I usually use a Hoffman elbow, but in these case series, they used a Barvelt tube and they shaped the tube on the table to be directed to the pars plana. The Bannock group described at 3 years, 75% pressure control, whereas Vinord's paper is much longer series. At 7 years, 45% of these kids had good IOP control. But what I want to direct your attention to is what's written in green. In the Vinord group, in the Bannock group, they did a vitrectomy alone, whereas in the Vinord group, they had a very good diagram showing using a Bosch and Lom's forceps to remove the wick, because if you didn't, that wick would go up the tube, causing failure and game over. So just to conclude, it's a useful adjunct in the armamentarium. Think about Yoda. There is no try. If you think something's going to fail, think outside the box and use a pars plana tube. We've seen, although having said that, we've seen the different surgical options we have. If you are considering the vitrectomy, the pars plana tube, ensure the vitreous base is removed to prevent occlusion later on. Thank you very much.
Thank you, Gurjit. That was a fascinating talk. And I'm also a Star Wars fan. I hope you saw Boba Fett. The series was excellent. Can I just ask you, as we open up the discussion again, could you clearly for the audience just say what are the factors that would make you choose a priori to put a pars plana tube as versus a anterior chamber tube?
I think there's no, I firmly believe that there's no definitives in medicine, and it's always up for debate, and it's good to have a chat with your colleagues and things. First of all, is anatomy. Second of all, obviously no space in the AC, difficult view. If you look at the literature, they talk about doing PKs prior to doing, obviously you need a view to do the vitrectomy. And furthermore, whether it's primary or whether we move on to it is a debate as well. So if surgeons have had other things gone awry and not worked, we can move on to that as well. Dual pathology, of course, you know, if there's a posterior segment problem, that would, or a vitreous hemorrhage, etc., that would gauge your mind towards that procedure in the first place.
And would you ever do pars plana in a fake child?
The potential is there. The key thing would be not to cross the midline. I don't think that is a contraindication per se.
Okay. Any other comments from the group on the use of tubes in these situations?
Can I comment? There'll be lots of surgeons in the world who don't have access to a dedicated pars plana tube. I just want to know what everyone else's experience is with regards to using a normal Barfelt or Armet and placing it pars plana so that it's in a situation where you have a very shallow AC, pars plana, but then doing a large peripheral iridectomy so that you can see the tube.
Can I just
I would say that the Ahmed company used to make a device for that, a clip, but I think they stopped making that. But I would just redirect the tube now and put it in. What were you going to say, Gurjit? I'm sorry.
To say that actually, like Alex, you just described, in both of those case series, they didn't use the dedicated Hoffman elbow pars plana tube, which I use in Oxford. And they just shaped it on the table. The key thing to try to avoid hypotony in that situation is not to put it in the sclerostomy sites where you've done the vitrectomy, because if there's a smaller lumen, that would have to be sutured and to make a different lumen adjacent to that and to put the tube through there. That would be the better option.
Yeah,
that's correct. A general discussion. Go ahead.
Just want to say quickly, at Bascom, I don't use the Hoffman elbow. I just use the regular tube and I do a sclerostomy. And as I'm aware, the other pediatric glaucoma surgeons do the same. We do a second sclerostomy for two reasons, because of the sealing and to avoid hypotony, but also because we want to direct it not as posterior as the sclerostomy would go, a little more like parallel on what would be the iris plane, but posterior to the iris plane.
What do people feel about mitomycin and tubes in kids?
I don't use it.
I think that's a great question. I think I have colleagues, and I'm sure people do use it. The key thing is for example, one of my questions to Ken earlier was, do you use the Ahmed in the anterior segment because there's a valve and there's that safety kind of aspect to it? If we're going to use MMC, what has the eye had done before? Because if we have someone doing lots of diode laser and there's a possibility it's going to be hypotenuse and you're giving MMCs, it's going to perpetuate that hypotony, perhaps it's not sensible to use. So I don't think there's a definitive right or wrong answer. The panel?
Yeah, I don't use it. Elena, you can just vote around the table. Are you an MMC fan?
I am not. If I don't see there's a clear benefit, which is not demonstrated, I prefer to avoid giving them a medicine that has those teratogenic and long life consequences without knowing there's a clear benefit, like in a trabeculectomy there would be.
Gorka and David, your thoughts?
Yeah, I would just like to, for this worldwide audience, I think it's really important to recognize that we've heard about a very specialized use of a tube. And the tube is a very, very valuable alternative for children with anterior segment dysgenesis, which unfortunately does include anomalies of the filtration angle. So to turn to a tube is a very important alternative. And in most instances, it's best simply put into the anterior chamber and in the way that we're familiar with. But it's been nice to hear about a very specialized procedure. I think it's important in the context of this presentation for us to mention and to share that we all have problems measuring the eye pressure in children with these problems. And it's really essential to be sure that, in fact, we're really dealing with a glaucoma problem. and to look for the other signs of increased pressure other than the tonometry values is really important. Is the anterior chamber deepening? Is the cornea enlarging? Is the eye itself enlarging? And then to take advantage of those clinical signs as well as all the alternatives to actually measuring eye pressure, and to be patient and make sure that, in fact, you're really dealing with a glaucoma problem. In terms of eye pressure measurement, finger tension is not reliable, but that's one alternative. The eye care tonometer offers an alternative. Handheld appellation tonometry is really valuable. And I would throw in that continued use of a Schiat's tonometer is absolutely valuable, and to get an idea about the anterior chamber. You can use it in a child who's supine, and to put that in and also follow the children that way. But I think we need to study these children carefully to be ensure that, in fact, patients who are seen with congenital corneal opacity really have glaucoma. And those, of course, who have newborn glaucoma type, that they have such conspicuous signs that I use tubes primarily for those children without going through the failures with angles. So to study these patients carefully, to be sure they have glaucoma, and to consider the alternatives. But tubes, we really should remind the whole audience, are very valuable and work well as an initial procedure, putting it into the anterior chamber.
Let's get back to the question. David, do you use mitomycin ever?
No.
And
No,
you,
I don't know.
Gorka, do you use the mitomycin with tubes?
No, I do not.
No.
Oh,
okay. So another question that has arisen is the foreign body of a tube. That's in there for a long, long time and put in. Does that concern anyone? And if you were to remove a tube, say there's a melt or something, and irreparable exposure, would you leave the plate in, or do you take the plate as well?
Alex, can I just talk about the last 22 years?
Ken, you're breaking up.
Now,
Ken.
20. Can you hear me?
Yeah, but you're breaking up.
Can you hear me?
Yes.
Okay, well, somebody else can go then. Can you hear me now?
Now we can, yes.
Not quite? Okay. So I was going to say, in the last 20 years, I have now on 27 occasions had to do a tectonic graft on a child referred to me because of a corneal melt, having had a tube put in the first 18 months of life. And those eyes, no matter what you do, are affected by amblyopia dramatically, because a tectonic graft it creates.
Can you switch off?
Can you switch off your video?
Because we're unable to hear you. You're breaking up. While Ken's trying to sort this out, perhaps
Sorry
any
about
other
that.
comments about?
So my comment. Can I comment on that? It said if you have happened to have done a vitrectomy for whatever reason, in a trauma eye, or I'm trying to think of when you would have done a vitrectomy and now you need to do, say your uveitis patient who's that's not an anterior segment pathology, but a uveitis patient who's had a vitrectomy, it doesn't make sense to put the tube in the anterior chamber. You should always put it as far away from the endothelium as possible. So if there's been a vitrectomy, you should be doing a pars plana, even if you're more comfortable and used to putting it in the AC, because of the long-term effect on the endothelium. So yeah, a lot of these anterior segment patients would not have had a vitrectomy.
And Dr. Freeman, I might say,
Sorry,
Elena.
Yes, sorry, just quickly, I agree completely.
Elena?
Yes, I agree, Dr. Freeman, exactly what you're saying, but always like just pointing out that you have to trust the vitreoretinal surgeon that has done the vitrectomy and be someone that is used to do the surgery on children, because that makes definitely a difference when it's going to be the clear vitreous and the eye like properly vitrectomized.
Gurjit, you wanted to reply?
Alex, I was just going to say, your point about whether to take the plate out or leave it be. I've just seen, like, if you do leave the plate alone and you sort of put the tube out and down onto the sclera, inevitably, in my experience, it just goes up and tries to give you exposure through the conjunctiva. Has anyone ever found that? So usually I take the whole plate out.
I don't take the plate out. And oftentimes
I leave the plate as well.
And oftentimes I won't amputate the tube. Life is long. I don't know what's going to happen. So I'll convert it to a stage 1, tucking the tube underneath. And I can say, like others on this conference, I've been doing it so long that I've had the need in the future to go back to that plate and put it in the pars plana for something else. You know, the person's had retinal detachment or something, and I'm like, oh, thank God I still have that tube there, and I'm able to put it in. And we don't use the Hoffman. I think it would be nice if we had it, but we don't have it. And I do, as Elena said, I do direct mine a little bit more anterior than what a normal sclerotomy would be for a vitrectomy. So we use a separate opening.
I had this available before I was at Bascom Palmer. So at Bascom, I did only without the Hoffman. I had that available. I actually like it better without it. But directing and doing a purpose sclerostomy, personal liking.
Can you hear me, Alex?
Alex, we can. Yep.
I was just going to say. So, Alana, do you do that even if you've had a melt? So I get these children referred to me with corneal melts, and you're having to do a tectonic graft. Under those circumstances, I remove the whole tube. Do you leave the tube even if you've had a melt in the cornea?
Yeah, I tuck it underneath the plate, Ken, mostly because like Alex, I don't want to take the plate off. You have those holes in a barbell where fibrous tissue has grown through it. And these are like pillars. And,
yes,
you can easily enter an eye if you try. And I've unfortunately seen something like that, but not at my hand. And I don't want to be there. So I really do leave the plate and just tuck the tube way underneath. I think if I'm afraid it's going to go through it, I might amputate and leave a stub so that I could always add a tube on top of it. And then I use sort of the Peng-Ka technique of tube over tube later on. And I've done that, but I do leave the plate.
Okay.
In
Nicole,
my experience, I've the few times I've had to try and remove a plate, it's almost been impossible. And I'm sitting thinking it's even tricky to, you're saying you tuck the tube in under the plate, but sometimes it's so fibrosed that it's impossible to get in under the plate. It's really difficult removing these plates after 4 or 5 years.
And you can enter the eye inadvertently trying if you try too hard. So word of caution.
So thank you, everyone. That was a great discussion. Thank you for brilliant talks, especially that they led to such good discussion. I'd like to finish off with everyone giving us one final comment, one pearl to take home for the audience from each speaker, please. Let's start with Gorka.
Brief. The treatment should be tailored. It's complex and should be tailored.
Eleanor?
So I would say think of angle surgery, at least as the first stage. It's important to keep that in mind, to give it a chance.
Thank you. David? One pull.
I've really enjoyed all the presentations and I've learned a lot, and thank you for the opportunity to participate. I guess the one pearl would be to look at each patient carefully, be sure they have glaucoma, and recognize the value of tubes, and recognize that angle surgery is an attempt to make almost normal tissue work better. So careful assessment of the angle is really important to judge whether or not that's a good procedure or not.
Thank you. And Gurjeet?
Well, one is if the pars plana tube is in play. Make sure the vitreous base is removed. Pearl 2, may the force be with you.
Thank you. And Ken?
Well, I hope you can hear me. I think deep phenotyping is really important. Please remember that the armamentarium for treating these children does include other parameters as well as goniotomy tubes. Think about cyclodiode, selective cyclodiode laser to buy time so these children get older and bigger, and you can do the treatment more safely.
Alex, but you're muted.
I would take moderator's privilege and have two pearls. One, just to extend what Ken just said, phenotype, phenotype, phenotype deeply, but also genotype when you're able. And number two, I think one thing that this has shown is there is no right answer. These are difficult cases, and there's many ways to skin the cat here. So do your best and keep the patient's best interest in mind.
Thank you.
I think my pearl goes on to Alex's, that there's no really right answer, but to try to do it as a team with others. And if you're somebody out there who takes care of children with glaucoma, join the associations that have other people who take care of kids with glaucoma. I've actually learned a lot here today myself, and I've been doing it for 30 something years. But I really am going to take some of the lessons that I've learned today and implement them. If you want to join the Childhood Glaucoma Research Network, CGRN, and we have regular meetings, we sent the announcement out for this one, then just go ahead and email the Balkan Center at miami.edu. So you see Balkan Center under my name there, Balkan Center at miami.edu, to join CGRN, Childhood Glaucoma Research Network. It's good to commiserate with everybody and share ideas. Thank you.
And Nicola, do you want to give us your final pearl? And then I'll take over to wrap up.
My final pearl was exactly that don't try and do it alone. These cases need advice. You press the button of colleagues who are willing to give their advice. Take pictures, share it with them, and get advice from at least 1 or 2 or 3 people before you tackle these cases.
Thank you. And I'm going to close with 3 other advertisements. One, the Pediatric Glaucoma and Cataract Family Association is available. It's an international organization for everyone and the patients who need support. The Glaucoma Research Foundation of Dr. Walton's. Join WSPOS, the World Society of Pediatric Ophthalmology and Strabismus. And we also have an international glaucoma registry that we invite anyone who has glaucoma patients to participate in. It's an open registry, free for you to use for your own research worldwide. And you can find out information by contacting me or through the CGRN. So in closing, I want to thank everyone for participating. It was a great session. I really feel honored to be part of it. If we missed any of your questions, please email them to admin@WSPOS.org, and you'll get an email response to those questions. Next slide, please. The future seminars, the next seminars coming, these are great: management of ocular problems in children with Down syndrome. And then a parent-patient centric session, Down syndrome and how my family and I dealt with it. It sounds like a fascinating thing, both in March coming up. Next slide. This is for season 3, worldwide webinar number 3, season 3. It sounds like a Netflix thing. Management of ocular problems in children with Down syndrome. Here are the speakers: Ramesh Kakunya from India, and others you can see here. I'm not going to mispronounce names. Looks like a great session. Next slide. And this is the parent-patient centric session that we just spoke about. And I'm sure you'll be getting reminders by email for those as well. So again, inviting the audience to join WSPOS. There's many membership benefits, as you can see. It's a great organization. And it is free. Everybody likes something free, right? So thank you very much. It was great. This talk, like all the talks, the worldwide webinars, are available for free on YouTube. If you've missed one, go back and see them. I want to thank our participants. I want to thank our audience. It was really great working with all of you. Thank you very much. Enjoy your weekend.
Thank you.
Thank you.
Thank you.
Thank you very much, everybody. Thanks, everybody. I learned so much. It was wonderful. I don't think we're live now. I think we're done.
Are we live,
Ken,
Akila?
I really did learn from you. I want to try that